Good morning. This is Shay coming to you guys with the preview for the Endocrine Lecture 3. I'm going to start with adrenal glands because I feel like that's a pretty difficult discussion. Today's video is being recorded on the morning of January 17th, 2023. If you guys have any questions, please reach out to me. The adrenal gland is very complex. It has a bunch of different layers. Um, a bunch of different hormones coming from the adrenal gland that are going to be really important later on when we begin discussing about the renin, angiotensin, aldosterone system, things like that. For our purposes, I think it's really important for you guys to know the three different layers: the glomerulosa, the fasciculata, and the reticularis. If you guys remember, I taught you a mnemonic: go, fetch, rex, salt, sugar, sex, being the zona glomerulosa, secreting salt or aldosterone, the fasciculata being sugar, secreting cortisol, because remember, cortisol makes up the glucocorticoids, the stress hormone response present within our body, the reticularis being the innermost of the adrenal cortex and it being responsible for the secretion of sex steroids. So again, this is just a cross section. I would hope if I give you a picture and I labeled this on an exam and I had A, B, C, and D, that you would be able to know the layers. And for example, if I said that a scientist took a cross section from this area right here and I had it labeled B, which of the following hormones would most likely be secreted from this area? As you can see here, it's a two-part question. One, you have to be able to identify what the zona fasciculata is, and two, you have to know the hormone that is secreted from the zona fasciculata, which would be, do you guys know? Exactly, cortisol or the glucocorticoids. I could go even further with that and ask you what is the mechanism of action of cortisol, or what is cortisol responsible for doing, and then you would have to know that it's various different responses, such as increasing the blood glucose levels in response to stress, or breaking down fat, or the different metabolic processes that occur. I could go down here or up here, for example, and I could ask you the same thing and want to know what the mechanism of action of the hormone that is secreted from this area. So you would have to know that one, it's a zona glomerulosa. Two, what hormone is secreted from the zona glomerulosa. And you would know that is aldosterone, correct? And then you would need to know what is aldosterone responsible for. Well, you know that aldosterone works in the kidneys by reabsorbing sodium, right, and secreting potassium. So these are just some ways that test writers like to ask questions. I hope that kind of makes sense to you guys, but we'll move on down here. So this is the hypothalamic pituitary response to stress. So remember, we have this neuroendocrine connection, the neural part being within this hypothalamus, right? The hypothalamus is going to release these releasing hormones. Anything that ends in RH, releasing hormone, is going to be the neural portion, right? This is going to be coming from the hypothalamus. So this upcoming exam is going to trigger stress. The stress is going to be perceived by the hippocampus, which is going to cause the release of something called corticotropin, releasing hormone. Remember, cortico is similar to cortisol, which is also similar to cortex. So that's an easy way to remember those. From here, the CRH is then going to cause the release from the pituitary. And that makes sense if you think about it, because if you can remember, like we previously said in our last lecture, the hippocampus is going to have, or I'm sorry, not the hippocampus, the hypothalamus. Again, the hypothalamus is going to have control over the pituitary. It's the control center of the pituitary. So the releasing hormone, or the CRH, is going to cause this pituitary to release ACTH, adrenocorticotropin releasing hormone, or ACTH. From there, ACTH is then going to go down to the adrenal glands, and it's going to cause the release of cortisol. So again, guys, a lot of this stuff is just memorization, just knowing that CRH, released from the hypothalamus, causes the pituitary to release ACTH, and in response, ACTH causes the adrenal glands to release cortisol. If you go back to that chart and you know that entire chart and memorize it, I can guarantee you that you'll be very successful on test day. Coming here, down here, again, this is, I know we covered this in the last lecture, but I think it's worth covering again. The cortex produces several types of steroids that include the hormones aldosterone. Do you guys know where aldosterone is produced? Which portion of the adrenal cortex? That's right, it's the zona glomerulosa. Remember, the GO in our mnemonic. Cortisol, do you know where cortisol is produced? If you guys zoom in on this picture, you'll be able to see this much better, but it's produced within the fasciculata, the fetch. And you guys remember the adrenal sex steroids are released from the reticularis, right? Go, fetch, rex, the rex in our mnemonic. So again, this picture over here on the right-hand side is just a memorization type of thing. Again, this is going to make sense. The more that you study it, the more this stuff is going to interplay and come together. Glucocorticoids are going to be responsible for raising glucose levels within the blood, especially in response to stress. It's also going to be responsible for reducing the inflammatory response. There are several conditions such as, for example, rheumatoid arthritis, where the body produces autoantibodies, right? Your body produces antibodies that attack the joints in the body. So during a flare of rheumatoid arthritis, whenever the disease process is very much in full effect, we will give patients cortisol. Essentially we'll give them prednisone. Have you guys ever heard of prednisone? Sometimes athletes will take prednisone whenever they get injured. And this is because glucocorticoids or cortisol reduces the inflammatory response. So two things that I want you to know about glucocorticoids or cortisol in general. Well, one, I want you to know where it's produced, right? Within the, do you guys remember? Fasciculata, right? The zona fasciculata, in response to what pituitary hormone? ACTH, absolutely. And from there, I want you to know what it does. It raises glucose levels in the blood and it reduces the inflammatory response, absolutely. Then, as you can see on the picture, the mineralocorticoids, whenever we talk about mineralocorticoids, I want you to think of aldosterone as being synonymous with that. Aldosterone is going to act on the distal convoluted tubule. Don't worry about that word just yet. This is part of the kidney. So I want you to know aldosterone works on the kidney by regulating sodium within the kidney. So aldosterone works by regulating sodium within the kidney. Good. Then I want you to know about the sex hormones. I want you to know where they're produced. Reticularis, zona reticularis, in response to what hormone? ACTH, absolutely. And then I want you to know that it is responsible for the production of some sexual features that we'll discuss later on. That's mostly going to come from testosterone and estrogen, but for our purposes, I just want you to know that it has an influence on hair growth in some instances. Then we can begin talking about the adrenal medulla. Here is just another picture depicting about aldosterone getting a little more complex. Again, these slides here are going to be very important to understand what I just said. Aldosterone causes the kidneys to conserve sodium ions. That's important to know. Conserve sodium ions. Secreted in response to increasing potassium ion concentration. That's important to know. This will be covered more in depth within our nephrology lecture or our kidney lecture about angiotensin 2. Remember, ACTH is going to cause the increase in response of only two of the three. Only two of the three hormones produced within the adrenal glands or the adrenal cortex. That's going to be primarily the sex steroids as well as cortisol. However, angiotensin 2 or Ang2, which is going to be a byproduct that we'll discuss later on, that's going to cause the increase in aldosterone. For our purposes, the only thing I want you to know at this point is that aldosterone works on the kidneys to conserve sodium ions. and it helps to maintain blood volume. How does it maintain blood volume? By increasing the amount of water present. Remember, uh, water follows salt. I want you to remember that. Water follows salt. So, because it causes an increase in sodium reabsorption, it also increases the water reabsorption as well, therefore increasing the blood pressure. Cortisol, I want you to know a few things about it. Cortisol is going to be produced by the fasciculata, right? The zona fasciculata in response to ACTH. If you remember this negative feedback system, this will most likely show up on your exam, as I think this is a very important context or concept to understand. The negative feedback mechanism is going to involve the secretion of, remember, the releasing hormone from the hypothalamus, this neural connection, and then it's going to cause the increase in ACTH from the anterior pituitary gland. And then we're going to have this increase in cortisol. It's going to be responsible for this inflammatory response, right? This anti inflammatory response, as well as raising blood glucose levels. These sex hormones are going to be produced by the gonads in response to ACTH, remember, secreted from the pituitary gland. And it's going to come in the form of DHEA for our purposes. You just need to know adrenal sex hormones. Let's get into the pancreas. So you have a 9-year-old boy presenting to the emergency room, complaining of increased thirst, increased uh, increased urination, and he has some weight loss. He's also because of something called polyuria. He's been continuously going to the bathroom. He's even wet the bed at night. They do a urinalysis on him. They test his urine, and they see greater than 100 blood glucose present within the urine. Uh, what's the diagnosis? You may have somebody in your family affected by this, but this is most likely type 1 diabetes. Okay. And this is going to get into the pancreas. We're going to discuss why this boy has diabetes. So, there are some different things that we need to get familiar with. Um, Diabetes is a condition that where your body produces antibodies. If it's type 1, antibodies against these beta cells. These beta cells secrete insulin. So, what does insulin typically do? Insulin is responsible for lowering the blood glucose levels, right? Insulin lowers blood glucose levels. Makes sense. If your mama or papa is a diabetic, they may take insulin after a meal. It's because after they eat the meal, their blood glucose rises, insulin takes it down. In the case of our patient, the 9-year-old boy, he has autoantibodies destroying these beta cells, which are responsible for secreting insulin. You got to think about it. If he doesn't have insulin, what can't he do? He can't lower his blood glucose levels. This is why patients with type 1 diabetes require insulin. Whereas those with type 2 diabetes, this is a little different mechanism that is a little bit above our understanding at this point. Type 2 diabetes, they can be treated with oral medications. But type 1 strictly have to require insulin. My whole point of making that connection with type 1 diabetes is I want you to know that beta cells, you're going to have 3 different types of cells within something called the islets of Langerhans. These beta cells that I was previously describing being destroyed by the autoantibodies, they secrete insulin. Okay. Insulin is going to be a hormone that lowers blood glucose levels. So, type 1 diabetic patients have autoantibodies that destroy the beta cells. Therefore, this lowers blood glucose level, or therefore they're unable to lower the blood glucose levels. These alpha cells within the pancreatic islets, these secrete glucagon. Glucagon is a hormone that raises blood glucose levels. And then the delta cells produce a hormone called somatostatin, HGH-IH. I just want you to know somatostatin. And then you don't have to worry about this F cell for right now. Going back to what the text says, the pancreas is both an endocrine and an exocrine gland. Do you guys remember from the very first portion of this endocrine lecture the difference between endocrine and exocrine function? Well, endocrine is going to be responsible for secreting hormone present within the blood, right, through the interstitial fluid, whereas exocrine secretes it through a duct. So, which duct do you think the exocrine portion of the pancreas secretes through? It's exactly right, the pancreatic duct. And it's going to secrete these digestive enzymes, such as amylase and bicarbonate and different things like that, that are going to be responsible for digestion. So I just want you to know the pancreas has two different functions: an endocrine function and an exocrine function. The endocrine function is going to be primarily the islets of Langerhans cells that we previously talked about. This is going to be glucagon, this is going to be insulin, and this is going to be somatostatin. For our purposes, I want you to know glucagon and insulin. I remember alpha cells within glucagon by this A here. I don't know why, but that's always stuck out to me. Whenever I've studied, I've always made that an uppercase A, glucagon alpha cells. I don't know if that helps you. Beta cells within the I just always remember type 1 diabetes, destruction of the beta cells. No, the beta cells are responsible for insulin production. Because you have destruction of the beta cells, you can't lower blood glucose levels. That's why they become diabetic. Moving on, we're going to discuss about the different functions of glucagon and insulin, as well as somatostatin. Glucagon is going to stimulate the liver to produce glucose. Therefore, it's going to increase the concentration of blood glucose. This is the hormone that happens within the fasting state. If you come to my class at 12:25 and you haven't eaten lunch or you haven't had breakfast, there's a chance that glucagon may be present and undergoing a process called the gluconeogenesis. If you get into biochemistry later on, you'll learn more about this process, but for our purposes, I just want you to know that glucagon works in the liver to increase blood glucose levels. There's actually a tumor that it's called a glucagonoma. Glucagonoma. We know that oma means mass, so it's a mass that produces glucagon. What do you think would happen? Well, if you tell me that you're going to increase the levels of blood glucose and have hyperglycemia, meaning too much blood glucose, you'd be exactly correct. There's some other things that go on with that, but primarily for our purposes, I just want you to know that glucagon increases blood glucose levels. What would happen if you had an insulinoma? Oma means mass, mass that secretes too much insulin. Um, what would this patient? What would happen? Well, he'd have a bunch of episodes of hypoglycemia or low blood glucose levels, right? So I don't know if anybody in our class has ever experienced hypoglycemia, but it's a terrible feeling, right? You're sitting in class and you start getting shaky. You haven't had anything to eat in a while. The blood glucose is just very, very low, right? It's typically you start feeling symptoms. I want to say some people are more sensitive, but I know below 60, you'll definitely feel symptoms, maybe even as low as 70. But again, you start getting very shaky. Your heart rate may speed up. You may feel like you're going to pass out. And that's just all because of the autonomic effects of hypoglycemia. But anyways, insulin is responsible for this is an important word: facilitated diffusion of glucose through certain cell membranes. This gets down to the chemistry aspect of it. We know that there's going to be different transporters present within these within the tissue, but for our purposes, just knowing facilitated diffusion of glucose, right? Insulin also does other different things. After you've eaten a rich meal, and if your body functions normally, after eating a meal, insulin is going to store some of this glucose for later use through the storage of glucose as glycogen. So, insulin can stimulate glucose storage in the form of glycogen. And we know that this is an important store because which hormone was responsible for breaking down stored glucose if you haven't eaten? Glucagon, absolutely. And this is why on our quiz we talked about the antagonistic effect of insulin and glucagon. I hope that kind of makes sense to you guys now about how insulin is going to be present in the fed state and glucagon is going to be present in the fasting state or when you haven't eaten. They work to oppose each other. This is how our body maintains homeostasis. This is another hormone secreted by the delta cells, somatostatin. Somatostatin is going to inhibit both insulin and glucagon. Release somatostatineomas, masses of the a mass producing somatostatin would both inhibit insulin and glucagon release. Again, just wanting you guys to know where the pancreas is positioned in relationship to the rest of the body. It sits directly inferior to the liver. It's in the central portion of the stomach, or not the stomach. I apologize, the abdomen. It has a very close connection to the large intestine, or I'm sorry, the small intestine. If you'll see here over on this present, it has three different portions. We call this the pancreatic head because it's the head of the pancreas. The body is the central portion, and you have the tail, which is over here. The head of the pancreas is going to have something called the pancreatic duct, and the pancreatic duct is going to come over here and closely connect to this common bile duct. This is a very important picture because the liver is going to have the gallbladder directly inferior to it, almost positioned on. It's actually positioned on the liver, right? This gallbladder has two ducts. The gallbladder has a cystic duct, which joins this hepatic duct. Hepatic means liver. I want to repeat this again. The liver has the hepatic duct and this cystic duct right here that forms something called the common bile duct. Okay, the cystic duct coming from the gallbladder and the hepatic duct forms the common bile duct. This common bile duct is going to be responsible for releasing bile into the second portion of the duodenum. This pancreas also comes into this second portion of the duodenum. Um, where do you think I'll just tell you, the most everybody knows about pancreatic cancer. Pancreatic cancer is deadly. It is the most lethal form, I would argue, of cancer within the body. Everybody, I'm not sure if you guys are aware, but it's so very rarely detected um, because the pancreas, there's no warning signs, right? The best place to have a tumor within the pancreas is in the head of the pancreas. The reason being, we can see the signs of pancreatic cancer. And what are the signs of pancreatic cancer? Besides abdominal pain and the um, besides abdominal pain and weight loss and things like that, there's something called jaundice. And jaundice is going to be yellowing of the skin, and it happens because of an increase in the amount of bilirubin. And we know that bilirubin is released through this bile duct coming into here. But if you have a big mass blocking this common bile duct right here, if it's within the head of the pancreas, and the common bile duct is going to be unable to empty into the second portion of the duodenum, then that would kind of let us know that, hey, there's something going on. And then we could pick it up on CT scan. So that's just a um, a real life situation that would kind of make sense with the anatomy, letting you know that a tumor at the head of the pancreas is the most survivable. Think about it. If there's something back here within the tail, it'd be very hard to even pick that up because there's no structures back here. Within the body, again, be very hard to detect that. But if we had something up here within the head, close to this pancreatic duct, um, close to this common bile duct, we had obstruction. Again, we would be able to pick that up. So, for our purposes, I just want you to know that there's a head, body, and tail. I want you to know the pancreatic duct enters into the duodenum. Coming down here, this is just another picture kind of telling you about these islets of Langerhans. These islets of Langerhans are going to be these clusters of cells within these something called acini. Acini are just clusters of cells, and within these acini are something called the islets of Langerhans. The islets are going to be the beta cells, delta cells, the alpha cells. I want you to know the beta cells secrete what? Insulin. The alpha cells secrete glucagon. Absolutely. Here's another kind of picture depicting the islets of Langerhans, just letting you know that these beta cells have a more central location, and the alpha cells are going to have a more peripheral location. Down here is another picture that kind of displays the complexities of the pancreas and liver, how they work together. We can go through this. If you eat a rich meal, blood sugar raises. This is going to promote insulin release from the pancreas, right? Once we lower blood glucose levels, the pancreas is then going to secrete glucagon, or I'm sorry, once we have lowered the blood glucose levels to a certain range. And if we haven't eaten, then we're going to secrete glucagon. Glucagon is going to stimulate the breakdown of glycogen. That makes sense, right? Glycogen, stored glucose. So we've eaten a meal. We've eaten a meal, the blood sugar's raised. What happens? Insulin's released from the pancreas. Awesome. We go through a period of time where we haven't eaten, blood sugar's starting to drop, glucagon starts to work. Glucagon works to break down that stored glucose that insulin had previously um, stored. So then this glycogen gets turned into glucose. And again, once that occurs and we start having this rise of uh, blood glucose, insulin's going to work again and it's going to lower the blood sugar levels. Moving on, we'll begin talking about the ovaries and testes. The ovaries and testes are going to be covered more extensively in the reproductive lecture, but I want you guys to have just a basic understanding of these. So we'll start with what the text says. The ovaries and testes are going to possess some organs that produce gametes. So gametes, I want you guys to know the male gamete is called sperm, right? That makes sense. The female gamete is called the oocyte. Does anybody know the process that occurs in order to form gametes? It's meiosis, absolutely. Meiosis, right? This forms our gametes. Do you guys know how many eggs are produced from each meiotic cycle? I believe it produces 4 gametes, but I'll have to look into that. You also have some polar bodies that are produced. So the ovaries produce estrogen and progesterone. I just want you to know about estrogen being primarily responsible for regulating the menstrual cycle. It's going to maintain pregnancy and prepare the mammary glands for lactation. Um, During puberty, once the oocyte has matured and we have estrogen production, this estrogen is going to be responsible for increasing the breast and widening of the hips at puberty. So you start getting these female features. The ovaries also produce something called inhibin, and inhibin is going to be responsible for inhibiting FSH secretion. You guys remember follicle stimulating hormone? Going back to all this, actually, the hypothalamus releases GnRH, or gonadotropin releasing hormone. Remember, it's an RH, so it comes from the hypothalamus. From there, it goes to the pituitary glands and causes the release of something called LH and FSH, luteinizing hormone and follicle stimulating hormone. Follicle stimulating hormone, or FSH, is then going to cause this follicle to mature. So once this oocyte begins to mature and begin the menstrual cycle, it's then going to produce estrogen, right? And because of the production, because of this FSH, and because of this estrogen production, inhibin is also going to be produced. And inhibin is responsible for that negative feedback, shutting off FSH. Relaxin is something produced. It helps dilate the cervix during labor and delivery. Important to know is that testosterone is going to be responsible for all of these things, right? It promotes the descent of the testes. So, have you ever heard this is a terrible term that the balls have dropped, right? The testicles have dropped. Well, this is just essentially meaning that puberty has happened, right? Testosterone is now present, and this is going to promote descent of the testes. Testosterone is going to be responsible for regulation of sperm. So, if males don't have enough testosterone in their body, they may be um, infertile. There's certain conditions in which testosterone is deficient. Therefore, men are not able to have to viably conceive with a female. Then the development of sexual secondary characteristics, right? Um, Androgen, it's just another term for testosterone. There's different types. Dihydrotestosterone is an androgen that is produced through an enzyme called 5-alpha reductase. We can get into this a little bit later. This is the female reproductive system. We'll cover it more extensively in the female reproductive cycle, but here you have the uterus. Within this uterus, you've got the endometrium, the myometrium, and the mesometrium. However, the outer portion of the uterus is going to be the cervix. The cervix has two portions, the internal os and the external os. Whenever women go to get pap smear, this is essentially going to be a scraping of something called the transitional zone in between here, the internal and external os. This is because there's a transition of epithelium between the internal and external os, and this is most commonly where cervical cancer likes to happen. So they'll take a scraping in between here. The vagina is obviously going to be the outer layer or the outer anatomical portion. Here it's just showing you follicles. Here's the follicle present within the ovary. Here are ovaries. Important to know that ovaries should not be palpable on physical exam. If they're ever palpable, chances are they are most likely there's a cancer or something going on. Here's your male reproductive system, showing you the outer area, the outer genitalia being the penis right here. Penis is made up of several different um, um, layers. We've got the testes within here. We've got the epididymis present on this outer portion. There's a condition called epididymitis in which you've got inflammation of this epididymis right here, and patients will get pain. However, if you raise the testicle or you put something under it in order to raise and take this pressure off the epididymis, then it actually diagnoses the condition. It's called a positive Ferin sign. Within here, some different layers. You've got the cremaster muscle, which is going to be responsible for raising and lowering the testes. The spermatic cord is going to be this cord that contains all of these structures. This is called the pampiniform plexus, which is going to be responsible for bringing most of the blood supply to the testicle itself. Then here's the testes. This whole outer layer here is going to be called the scrotum. Epididymis is going to be responsible for sperm maturation. Here's the muscle, the tunica dartos muscle. The vas deferens is going to be another layer. You can know how sperm travels by the mnemonic 7 up. You've got the seminiferous tubules, the epididymis, the vas deferens, the ejaculatory duct, nothing, then the urethra and the penis. That is exactly the way that sperm will travel. It'll go through the something called the seminiferous tubules. It will then go to the epididymis. From there, it travels to the vas deferens. From the vas deferens, it'll travel to the ejaculatory duct, which is not present on this picture. N stands for nothing. U stands for the urethra, present right here. And then the penis. Moving on to, again, we'll come back to male and female reproductive. Just want to give you guys a brief overview. It's not going to be important for this lecture's purposes. Other things that we do need to be aware of are something called the pineal gland. Pineal gland is going to be responsible for circadian rhythm. Again, I want you to know about that, the sleep and wake cycles. Whenever you go into a room or you're at night, you turn the lights out, you turn the lights down, you close your windows, it's going to cause the secretion of a hormone called melatonin. Pineal gland, so the pinealocytes or pinealocytes secrete the hormone melatonin. This is a very small endocrine gland. It's attached to the roof of the third ventricle. Don't have to know where that is. This is just going to be an anatomical location within the brain. So the more darkness, the more melatonin, and thus the sleepier you get. There is a disorder. I don't know if you guys have heard of this. It's been more widely studied today, seasonal affective disorder, or SAD. This is depression associated with long winter months due to the overproduction of melatonin. And it makes sense. So you get these long winter months, which means that we get less sunlight, which means we have the production of more melatonin. There's been new research showing that having a certain type of light, artificial light, that you can actually reduce the amount of melatonin that is produced, which has been showing to be a widely used, effective therapeutic tool that we can do. Here's just another portion to show you the pineal gland in relationship to the optic chiasma. You've got this here in relationship to the pituitary gland. Remember, we said that if you had a pituitary mass, it could cause visual changes within the optic chiasm. Here's the hypothalamus. And the pineal gland is just a little bit posterior to it, or um, caudal to it. If you were to do a CT scan, the pineal gland will show up calcified. That's actually a normal finding. If you have calcification of the pineal gland, it's very normal. We'll discuss the thymus. The thymus is going to be a gland that is going to be larger whenever you're younger. The reason it's larger when you're younger is because it's responsible for the maturation and production of something we call T lymphocytes, or your memory cells, the cells that are going to be responsible for remembering if you've been previously infected, or it's also responsible for class switching, producing antibodies, things like that. Um, you're forming your immune system when you're younger, and as you get older, you don't produce as much T cells, if any at all. This is why the thymus isn't needed, therefore it begins to shrink. This picture here is going to depict an adult. As you can see, you can't really see the thymic shadow here. Here is a picture of a child, and this is a thymus here. So it lies posterior to the sternum. That makes sense if you were to think about this being in terms of anatomy, this being the sternum itself covering here. The thymus is going to be directly posterior to it. It shrinks with age, secretes something called thymosin, which affects the production of certain lymphocytes. The lymphocytes are going to be the T lymphocytes. T for thymus. T lymphocytes for thymus. And in turn, it provides immunity. This is just a picture depicting exactly, again, this is going to be sternum, the outer portion, and it's directly posterior here. If you were to break the thymus up, you would be able to see the different areas. It's an encapsulated organ. We will go over a little bit in terms of the stomach as an endocrine gland. We're going to have a whole gastrointestinal lecture. Therefore, we'll just briefly cover these. There are several hormones that are going to be needed. Again, whenever we talk about endocrine, we're talking about hormones that work at a distant site, right? And they're secreted through the blood. Okay, so your body has to digest food. In order to do that, it produces these hormones. Gastrin is going to increase the amount of gastric fluids or gastric acid. It increases movement of the stomach, promotes release of gastric fluids. GIP, glucose dependent insulinotropic peptide, GIP, causes the pancreas to produce insulin. It makes sense. Glucose dependent, insulinotropic. So we need glucose. Because glucose is present, it also causes the production of insulin. So GIP from the stomach or the digestive tract is going to cause the production of insulin release from the pancreas. Secretin is going to be an important one. This is going to release something called bicarbonate or HCO3 in order to alkalinize the production of stomach acid. CCK or cholecystokinin, this causes the gallbladder to contract and release bile. So if someone were to come in with right upper quadrant pain radiating into their shoulder or their back after eating a rich meal, what's the diagnosis? If you're telling me that this is a gallbladder attack, then that would exactly be right. CCK or cholecystokinin is going to be the hormone that is responsible for the release of bile. They eat this fatty rich meal. The fat stimulates bile release, so it causes CCK to release this. CCK is going to be the hormone that would be primarily high if you were to test it. We don't commonly do that in practice. Instead, we'll get an ultrasound, but CCK would be high if you were to test it within the body. When you think of the hormone ghrelin, I want you to think ghrelin because this increases the appetite before a meal. So if your stomach's growling, it's probably because of ghrelin. I think you guys will probably remember that one. So again, just to summarize these important points, gastrin is going to produce gastric acid, right? It's going to promote the release of gastric fluids. GIP, glucose-dependent insulinotropic peptide, causes insulin release from the pancreas. Insulin's in the name. Secretin, this one might be tough. Secretin secretes bicarbonate, HCO3, through the pancreas. CCK Cholecystokinin cause the gallbladder to contract, C for contract. Ghrelin is growling because why? It's we're hungry. You know, we're promoting, we're increasing our appetite before the meal, and it decreases after. Check on learning. Receptors for fullness are found on the top of the stomach. How then can overeating become a positive feedback loop in obese patients? How does this make gastric bypass successful? Well, we know that gastric bypass is successful because if you take out those receptors present within the stomach, then what? You're not going to be as hungry, right? This is going to prevent ghrelin from increasing the appetite before the meal. Here's just another picture depicting the anatomy. There's different areas present here. On this outer side, we call this the greater curvature. This is on the outer portion. This lesser curvature is on the inner portion here. There's three different things that I want you to know. This is the body, which is going to be present within it's the majority of the stomach itself. This is the body. These folds within this body are called rugae, Rugae, rugae. These have a very distinct look when you dissect them in the anatomy lab. So the main portion is the body. It's going to be on this outer portion. The fundus is at the top. And then emptying into, this is the small intestine down here, but you can't see it. This is called the pylorus. And it has a sphincter right here, the pyloric sphincter. Okay. This allows food to, once it gets into here, to pass into the small intestine. There's a bunch of different arteries that supply the um, supply the stomach. Again, the spleen has a very close relationship, so you get the splenic artery coming back here. We won't go through all these. I primarily just want you to know that the stomach is a very vascular organ. Here is an example of a Rowan Y type of gastric bypass procedure. They don't do these as much anymore. This is just showing you how they do it. This picture here is depicting adipose tissue. These big white cells are the adipose. They produce a hormone called leptin. Leptin is going to be a hormone that is going to sense and give your body a full feeling and tell you to stop eating. So leptin's good. Leptin is going to let you know that, hey, I have satiety or I'm full. So it's a type of adipose tissue is a type of loose connective tissue that stores fat. Produces a hormone called leptin. Leptin promotes satiety, makes you feel full. Essentially, it's the opposite of ghrelin. Remember, ghrelin makes you feel hungry. So let's say that we had I'm not sure if this exists, but let's say we had a tumor that produced too much ghrelin. What would you expect to happen? Be a lot of weight gain, right? There actually are conditions in which ghrelin is overproduced, as well as leptin being overproduced as well. In which I think Prader-Willi syndrome. This is a childhood syndrome in which there's a chromosomal deletion. There's overproduction of something called ghrelin, right? Ghrelin, and because they get an overproduction of ghrelin, these children are very much more prone to becoming obese. Leptin is going to essentially be the opposite of ghrelin. This is going to make you feel full. Therefore, you're going to eat less and more likely to be skinny. This here is just showing you the homeostatic mechanism. The hypothalamus is going to, the food intake down, energy expenditure. Food intake is down, energy expenditure is up, sympathetic activity up. So adipose tissue, weight gain. Because of the gain of weight, we have more adipocytes. Because of the more adipocytes, the leptin levels rise, which is going to cause us to decrease the amount of food that we take in, which is going to allow our energy expenditure to be up because of this breakdown of fat and cause our sympathetic activity to increase. As leptin levels during weight loss, the leptin levels are going to fall, which is going to cause the hypothalamus to want to increase the amount of food, downregulate our temperature, and so on and so forth. This is a genetic knockout receptor for leptin. As you can see here, leptin has been knocked out. because leptin has been decreased. What do you think's happened? Right, there's no shut off for increasing the amount of. There's no shut off to decrease the amount of food intake. We never get that hungry. We never are not hungry. If that makes any sense. These slides here are just going to talk about stress and lifespan changes. Not as important for us. Of course, stress is important. Um, Stress occurs when the body responds to stressors. That makes sense. What is a stressor? Well, a stressor is just a factor that stimulates stress. So that could be this class, for example. This class may be a stressor. You may have financial responsibility, which is a stressor at home. You may have kids, which are primarily going to be um, a stressor. Um, Taking care of them, while you're trying to maintain school, um, that could be a stressor. Because of the stressors, whenever we're not able to, there's two types of stress. There's eustress, which is good stress, right? And there's something called distress. This is stress that is becomes harmful. Um, Either way, our body has a built-in response mechanism to deal with this stress. And this is caused by the increased activity of something called the sympathetic nervous system. You guys should remember the sympathetic nervous system from A&P1. Sympathetic nervous system is going to be your fight or flight system. This is going to cause tachycardia, or the increase in heart rate. It may cause you to increase sweating, causes your eyes to dilate, things like that. Because of this increase in sympathetic tone, there's also an increase in the secretion of adrenal hormones. Here are the types of stress that I talked about. Eustress occurs in response to situations that bring about mostly positive emotions, but are still unsettling. A lot of people, here's the example of kids. Um, Raising a child may be stressful. I'm sure it exactly is. I don't have any kids, but I can remember my parents raising me, and there was often times of stress. However, this was eustress. This was uh, doing something that they wanted to do, a positive emotion, right? It could be studying. You study and it becomes stressful. However, if it's eustress, um, if it's often you'll study and it becomes eustress because of the good grade you receive. Distress occurs in response to dangerous situations. This could be you're out hunting and there's a bear sitting right underneath you in the tree stand, right? You're in a distressful situation. Chronic stress occurring for longer than 21 days in response to situations or daily life. This could be things due to malnutrition. This could just be your job. You have chronic stress due to your job because you go to it day in and day out. Different types of stress, physical, whether it be from environmental factors. It could be psychological stress. You could be in an abusive relationship. I hope that nobody is not. But these are all different things that can impact the amount of stress that occurs. Because it impacts the amount of stress that it occurs, it can also cause an increase in the sympathetic nervous system. Because it increases the sympathetic nervous system and increases the secretion of these adrenal hormones, primarily cortisol, primarily epinephrine. Response: the hypothalamus controls a general adaptation syndrome. Responses to stress work to maintain homeostasis. Persistent stress can lead to exhaustion, which may be fatal. This is just a picture that is more or less for your studying purposes. We'll go over this more in depth in class. This is a great way to study the fight or flight response as well as homeostasis and understand how the hypothalamus pituitary controls itself. This here are slides depicting lifespan changes. If you want to get depressed about getting older, read about some of these. Um, some of them not so bad, right? As you get older, we're more prone to muscle loss. That's because growth hormone levels even out. Uh, Thyroid shrinks, right? But controlled metabolism still continues. We have lower levels of calcitonin, increased levels of parathyroid. We have an increased risk of osteoporosis. Uh, like I said before, thymosin production declines. Remember, thymosins produce where? The thymus. Makes sense. Changes in melatonin secretions affect the body clock. This is a big one. If you think about sleep within the elderly are going to be more prone to wake up early, go to sleep early. They will wake up around 4 or 5 a.m. They don't really require much sleep to function as much. Guys, this is pretty much the lecture. We'll have a review before we get into our first exam, but this is the first endocrine lecture. If you guys have any questions, please feel free to reach out to me. Again, I'll cover the highlights, the high yields in class. Thank you so much. You guys have a great day.